All right, so let's start the section. So today we're going to be discussing about acute coronary syndrome, and we'll be talking about the anticoagulants at the end of the section. So let's jump right into it. So as we all know, what is acute coronary syndrome? So we have the myocardial infarction. We have the we classify. So what is basically myocardial infarction is like heart attack. So before going into the section in depth, let's classify, like let's see what's the difference between angina, MI, and heart failure. So basically, in angina, we discussed that patients will have chest pain. So patients actually comes up with the chest pain, and patients' chest pain can it relieved by rest, and it actually precipitated by any exertion, right? So it's kind of stable. So the myocardial infarction is we said that most common cause for the angina is coronary artery disease. So in angina, there is kind of a partial block and it leads to myocardial ischemia. But when it comes to heart attack or myocardial infarction, it basically the patient have a full heart blockage. Not heart blockage, like the coronary artery is completely blocked, which lead to the death of tissue surrounding the heart, like the myocardial tissue, which leads into heart attack. So that is the one difference. What about the heart failure? So heart failure is actually a chronic condition where the so patients had the heart attack. Now patients have the chest pain, and slowly, sometimes patients will not develop the symptoms of heart failure. At one point, when they check for the functions or when they check the ejection fraction, they'll come to know the heart is pumping very weak because the muscles try to remodel. Right when the tissues die, the heart tissues dies. It's replaced with the fibrous tissue, and it's what we call remodeling. So the which leads to heart failure. So eventually, the heart failure, the cardiac output goes down and leads to heart failure. So you always have to make sure to differentiate the myocardial infarction and angina and heart failure. And always don't confuse the treatment. It seems when we go through the treatment, you will see that there is kind of the post myocardial infarction treatment and the angina is kind of almost like similar. So we will know when we discuss. Okay. So in myocardial infarction, we have the STEMI and NSTEMI. So NSTEMI is like um, ST segment elevated myocardial infarction, and NSTEMI is non-ST elevated myocardial infarction, or we call it as unstable angina. So what is the difference it makes is the unstable angina. So in stable angina there is a ongoing. So it's precipitated by the exertion, it relieved by rest, and it's it's the same. It's keep on. There is no ongoing progress in that. So in unstable, it's really this has the name sounds itself like it's really unstable. Like the pain comes, it's not predict. Sometimes pain can be from rest, where even the patient at rest develops the pain, chest pain. It can be due to exertion. So it's really like not frequent. It's like comes and it progress has the as it moves forwards, its progress as well. That's why we call it unstable angina. Okay. Now, let's have a look at the clinical presentation here. So again, the patient says they have chest pain, and sometimes the patient feels just like a neck or jaw pain or kind of stomach pain. So patients have a palpitation, nausea, diaphoresis, which is excessive sweating for no reason. Like so, it's not for no reason. Like especially if there is a condition with the body, and if the patient excessively sweat, and shortness of breath, lightheadedness. Um, and on physical assessment, we can see that. So here, what happens, like if once the patient develops this clinical, like the symptoms, we give the sublingual nitrate, same as we do in the angina. And if there is no relief 5 minutes after first sublingual nitrate dose, again, all the time we can give maximum 3 doses of sublingual nitrate dose. We cannot exceed maximum of 3 doses, and we have to give every 5 minutes. And if there is no relief, so we call the ambulance right away. regardless of we give sublingual. So the patient develops the chest pain and complains about the chest pain. The first thing we do is give the sublingual nitrate, then we call the ambulance, right? Now, we check for the physical assessment, so hypo or hypertension. It can be hyper or hypertension, cold and clammy skin, and jugular venous distension. That's what I saw in the image here. As you could see, this is what the jugular venous, internal jugular vein. So there will be a distension of that, and patients can have the symptoms of like pulmonary edema, so we can do the assessment for that as well. And we call the ambulance, as we said, despite if we treat with sublingual nitrate. What happens once the ambulance arrives? So, and usually all the ambulance and stuff, like they carry the emergency card medication, right? And even if it's not like the emergency, if the patient's if the patient has gone to the emergency for a family member, the first thing they do is they start on Mona. So in myocardial acute myocardial infarction, like they start the patient on Mona. So what is Mona stands for? So M stands for morphine for the pain. So morphine, then oxygen is really important. So oxygen, so the target so oxygen as needed. So that means if the patient oxygen saturation is above 90, we really don't have to give the oxygen. But if the patient's oxygen is below, the saturation is very low, then we have to start the oxygenation. So oxygen, then sublingual nitrate. So unless the systolic blood pressure is less than 90, we give the sublingual nitrate. Then we give the aspirin along with that. So we said yesterday in antiplatelets, aspirin 160 to 325 milligrams actually given acute myocardial infarction to decrease the mortality, right? So again, we give the aspirin. So this is the first thing. As soon as possible, we have to do this. What we start the patient, that's we call it as MONA. So morphine, oxygen, nitrate, aspirin. All good? Okay. Now we have some non-drug measures for the patient. We bed rest with continuous ECG. ECG is really important here. Why? Because ECG, so what the physician does is they will do the ECG stat. Why they have to differentiate if the myocardial infarction, if it is STEMI or unSTEMI. It's really important to differentiate if it's STEMI or unSTEMI, because based upon that the treatments has to be done. So we'll be discussing the difference between the STEMI and unSTEMI and what is the difference in the treatments moving forward. But again, ECG, they do this ECG start so immediately. So again, bed rest with continuous ECG. Then if the patient is stable and no complications, it's okay to mobilize the patient. Now, immediate assessment. What are the things that included in the immediate assessment? So we check for the pain quality. Like we ask for the pain quality. So the severity of the pain. What is or the location? Is it substernal? It can be radiated to jaws, shoulders, right? What are the trigger factors? What are the relieving factors? So we take the history of that from the patient. Now, what are the cardiac risk factors involved? So we know what are the cardiac risk factors. So we ask that. Now, ECG, like I said, start then every 8 hours for 1 day. Then we take daily. Then we take the serial troponin. So why serial troponin? Because troponin is one of the, when I discussed heart failure, the best marker is BNP, but when it comes to myocardial infarction, acute MI, especially, so don't confuse heart failure, heart attack, totally different. So heart failure is something chronic, progressive situation where the ejection fraction goes down and cardiac output goes down. Heart attack is something different. So it's heart attack happens, or we call it as myocardial infarction. So in that case, the best marker is troponin. So it actually elevated within like 12 hours after the heart attack. So it's really a good marker for the diagnosis of myocardial infarction. So again, they take it serial troponin. So it's not just one. They keep on taking this troponin level. And If they reaches the threshold, if a diagnostic threshold, then they do it like every 8 hours and they keep monitoring. Then sometimes if the troponin is not available, then we do the CKMP, which is specific for the heart muscles, right? So that then within 24 hours, we have to make sure we do the lab investigations like for the CBC, electrolytes, blood glucose, lipid, and liver function, and all those things. And there can be other causes for the in myocardial infarction, or it can be hyper or hypothyroidism. So usually hyperthyroidism, so not hypo, so hyperthyroidism. So sometimes the patients, we know that in hyperthyroidism, the tachycardia is one of the symptom, right? So it can lead angina, it can precipitate angina in some patients, like chest pain. We do the iron panel. If the patient is anemic or not, we do the chest X-ray. We take the ECG. We rule out the arrhythmia. We also do the check for the complications. If the patient have any heart failure, any conditions like ventricular dystrophy or something, hypertrophy. So we do the echocardiograph, right? And also sometimes we have to be very careful here. We have to check if the patient is on phosphodiesterase inhibitor, because we discussed in nitrates, the phosphodiesterase inhibitor is contraindicated with nitrate. So they should not administer both at the same time. So it's really important because patients can use, it's really commonly used medication without a prescription. I mean, in Canada, we need a prescription, though. In India, I think we get it over the counter. People use in a daily use, like people take the sildenafil, right? So it is really important when the patients have a heart attack to check if the patient is using the PD5, phosphodiesterase 5 inhibitors. Okay, now how do we classify if the chest pain or the acute MI is STEMI or NSTEMI? If the chest pain continues for more than 30 minutes, so first criteria, if the chest pain continues more than 30 minutes. Now the second criteria is if the ST segment elevation on more than 2 adjacent leads. So 2 or more than 2 adjacent leads. So if the chest pain continues 30 minutes, or if this just, then we'll do the ECG, right? So I said ECG is really important to do. So in ECG, if there is a ST segment elevation, just not in one lead, it has to be 2 or more than 2. Okay, more than 2 adjacent leads. So if it is yes, then it's STEMI. If it is no, that means the patient is having an unstable angina or NSTEMI. All right. Now, let's have a look at how the ST segment elevation here. So we know the normal ECG pattern. So here, if you see here, the ST segment elevation in STEMI is like this. So the ST segment will be elevated about the isoelectric line. So here we can see, so these are the two patterns you sometimes we see in NSTEMI. So sometimes it can be ST segment depression, or it can be T-wave inversion. Okay, so these two usually seen in NSTEMI or unstable angina, but here the ST segment is has the name implies that it's seen in STEMI, ST segmented, ST elevated myocardial infarction. Okay, so you don't have to know this pathological QA, but yeah, just for the reference. Now, let's discuss about STEMI. So what are the goals? We have to prevent the mortality. We have to prevent the remodeling of the heart. So I said that when the heart tissue dies, the body replaces it with the fibrous tissue and try to remodel. So once it becomes the fibrous tissue, it's not gonna work. It's not gonna help in contraction of the heart. So we have to prevent the remodeling. We have to prevent the complications. What are the complications? Heart failure is one of the complications. So we have to prevent the complication. We have to prevent the infraction. We have to reduce the infarct size. We have to reestablish the patency. So these are the goals of STEMI. And how do we achieve that goal? So now, first thing, we start or continue the beta blockers. So why? Because in angina, we take the long-term therapy. So sometimes if the patient have a history of angina, stable angina, So the patient is already on beta blockers, right? Because patients, unless the patient choose not to take it, right? So we actually start the patient on long-term beta blockers that we discussed in angina. So if the patient is on angina, we continue it. If the patient has not on, patient on beta blockers, we continue it. If the patient is not on beta blockers, we start the beta blockers. Now, if the myocardial ischemia is ongoing, then we add the nitroglycerin oral, and if it persists, despite of the nitroglycerin and beta blockers, we add additional calcium channel blockers. So it's similar. The first part is kind of similar to how whatever we did in the long-term treatment of angina, right? So there is no much big difference here. So what is the difference in the treatment of STEMI is the next one, PCI. So PCI stands for percutaneous coronary intervention. So the first choice. So we does this. It can be done like on the way to the hospital, or it can be done once patient reach the hospital, which the first part. Now the patient reached the hospital. So if the facility or if the hospital have the PCI, if they do this procedure PCI, the PCI is always the first choice. And one thing you have to remember is it has to be done within 90 minutes of having the chest pain. So again, it has to be done within 90 minutes, at least 90 minutes. Okay. Now, can we recommend this to all patients? Yes, we can recommend to all patients, but especially the patients who are above 75 years, and patients are relatively or absolute contraindicated to thrombolytic. So we know the thrombolytics is the drug of choice here. And if the patient, what are the few absolute contraindications to thrombolytic, guys? Like if the patient having hemorrhage, right? So thrombolytic agents are now absolutely contraindicated in certain situations. So what are the situations? Tell me, what are the few situations where it's absolutely contraindicated? If the patient have an active intracranial hemorrhage, right? So they take the CT scan, and if the patient have an active intracranial hemorrhage, thrombolytic is absolutely contraindicated, right? If the patient have an active internal hemorrhage, so for example, if the patient was in a car accident and came to the hospital. Now the patient having a cardiac arrest, and the patient having really bad, internal bleeding. Can we do the thrombolytic? No, we cannot. So in that case, we have to go with percutaneous coronary intervention, right? And patients with bleeding tendency, like if the patient is like a normal INR is more than 1.7, so do not confuse with the INR of the mm, uh, when we start the warfarin, the INR target is like 2 to 3. Do not confuse that. It's a normal. In normal patient, the INR, if it is above 1.7, then we cannot start on thrombolytic. So there are some absolute contraindication. You should know at least the absolute one. Even though it's not, even though you don't know the relative contraindication, it's fine, because sometimes the physician go with benefit risk assessment when it comes to relative contraindication, but absolute contraindication you should know. Okay. And again, if the patient have cardiogenic shock, we cannot, those are the candidates for percutaneous coronary intervention. Now, sometimes we start, so usually we give the clopidogrel 300 milligrams to 600 milligrams pre the procedure, okay, before the procedure. So why? Because it seems to decrease the death and the reinfraction. What happens if the patient cannot reach the facility or the hospital in 2 hours? So it sometimes like a block came and the ambulance reached the facility like after 2 hours. Now we cannot do the PCI. There is no point in doing a PCI here. So what we do is like we go with pharmaco-invasive strategy. So again, if the patient reaches the facility after 2 hours, we go with pharmaco-invasive strategy. So what does that mean? So pharmaco stands for pharmacological. So we start the patient on the drugs, then we do the invasive. So we give the thrombolytic first, then we send the patients to a facility based upon the condition of the patient. We send the patient to a facility or the hospital where he can get the PCI. How do we do the So now let's have a look at how we start the pharmaco strategy first. So we initiate the thrombolytics like at a place, one of the thrombolytic agent, or and we have to start with 6 hours of symptoms. So within 6 hours of symptoms again. So these time is really important. So initiate the thrombolytic, but we have to start within 6 hours of symptoms. If it is above 6 hours, it's not gonna. Can we start it after the 6 hours? Yes, we can, but the effect is gonna be very less compared to if they start less than 6 hours. So we start within 6 hours of symptoms. So usually in emergency they call it as door to needle time is 30 minutes. That means once the patient reaches the door of the emergency to the needle, it has to be 30 minutes. So overall, it has to be start within 6 hours. But in emergency, they call it like the patient. Once the patients reach on the emergency, the time to after doing all the ABC analysis and stuff, they have to inject the thrombolytic within 30 minutes. So door to needle time is 30 minutes. And if the patient can the patient, like I said, can the patient use it after the 6 hours? Yes, but the less benefit, right? Now also we add the IV and fractionated heparin, so for 48 hours. So if we cannot use IV and fractionated heparin for some reasons, we can use low molecular has an alternatives, and ensoparin is the best alternative. Sorry, ensoparin. Then we add the aspirin, 81 milligrams, and the baby aspirins, right? And we also add the clopidogrel for more than 30 days. So we are at least for 30 days. So we consider the clopidogrel, if the patient is less than 75 years old, we consider the loading dose of clopidogrel for 6 days. When then we send the patients to a facility where we can do the PCI. So again, we start the patient on beta blockers, nitroglycerin and calcium channel blockers. We does that. It's the same as the angina long-term treatment. Now, what makes the difference is the PCI. So if the patients can reach the facility within like 90 minutes or less than 2 hours, we do the PCI. Okay, and especially there are some candidates for it, especially the patient of more than 75 years, because why? So more than 75, they have the high risk of bleeding. So that's why they are the candidates. So more than 75, if there is a absolute contraindication to thrombolytic, cardiogenic shock, and pre-PCI, we start the patient on clopidogrel, 300 milligram to 600 milligrams orally. And if the patient cannot reach in 2 hours, what we do, we go with the pharmacoinvasive. So that means we start the patient on thrombolytic, and the thrombolytic has to be started within 6 hours of symptoms, and the door to needle time is 30 minutes. Then we add the IV and fractionated heparin, we use the aspirin, we use the clopidogrel, we use the loading dose of clopidogrel if the patient is less than 75 years of age. Why not in more than 75? Because more than 75, like we said, the risk of bleeding. So we don't want to give a loading dose of clopidogrel in patients above 75. So we usually give only in patients below 75. Okay. So are we clear so far? Now, okay, so now let's see NSTEMI or unstable angina. Here, the goal is to prevent the mortality, to prevent the complication, to prevent the infraction, to prevent and to reduce the pain or ischemia. So, what is the two different things here? If you see the goal, we don't have to prevent the remodeling here because the tissue is not dead yet. It's just a partial blockage of the artery. So it's not a complete occlusion. So the tissue is not started to die. So we don't have to worry about the remodeling part. And also, other thing is to reduce the pain and ischemia. Here, it's similar as how we did in the angina. We have to reduce the pain and ischemia. So ischemia is like low due to decrease in blood supply, right? So we have to reduce the ischemia. Now, how do we do that? We continue the oxygen. If the patient needs oxygen, we continue the oxygen because it's decreased blood supply, so decrease the oxygen, right? So we continue the oxygen. We give the sublingual nitrate. If there is no relief in 15 to 20 minutes, what we do is like we switch the patient to IV. Okay, so IV nitroglycerin, and We can also consider the IV beta blockers. Okay, so sometimes in recurrence we can give long-acting one, and also we can consider the IV beta blockers if the patient's chest pain is like, if the patient have ongoing chest pain, we consider the IV beta blockers. And despite the nitroglycerin and beta blockers, if the patient still have the pain, we can add IV calcium channel blockers. So here one difference is that the patient is using IV rather than oral. So in STEMI, if we see the patient, we start the same. We start with the same kind of things: beta blockers, nitrates, beta blockers, and calcium channel blockers. But we did orally. But here we doing it like, because that's the mainstay of therapy here. So we don't do the PCI, as you could see, as it's not the first choice in this patient. So we give IV of beta blockers, IV nitrates, and IV calcium channel blockers. Now we also start the patient on heparin. So here, the first choice is low molecular weight heparin. Unlike in STEMI, we use the unfractionated heparin, right? Here, the first choice is low molecular weight heparin. So we give it for 2 to 5 days. Okay, again, we give it for 2 to 5 days. And one thing we have to here notice is like creatinine clearance of patients. So if the creatinine clearance is above 30, we can give the low molecular weight heparin. If it is below 30, we have to go with unfractionated heparin, because we said in the drug class when we discussed yesterday about unfractionated heparin and low molecular weight heparin, unfractionated heparin having dose dependent kinetic, and it actually at low dose it's excreted, it eliminated through endothelium, and at high dose it eliminated through renal, which make it more advantage. What is the best advantage? Like, it make it more it can be used in renal impaired patient, the unfractionated heparin, right? So if the creatine clearance is less than 30 mils per minute, we use the unfractionated heparin. And another alternative is fondaparinux. So we usually commonly not don't use it, but that's the one of the alternative. So we said, if you guys remember that in heat, we use the alternative. First, best evidence has the the fondaparinux, right? So we use it in the heat. So again, it's really important. The first choice is low molecular weight heparin for 2 to 5 days. Then we use the alternative unfractionated heparin and fondaparinux. And now we start or continue the aspirin with clopidogrel or ticagrelor. So again, low molecular weight heparin and fractionated heparin as alternative, and we continue the aspirin if the patient is already on antiplatelets. We continue the aspirin. If not, we start it. Here, the one difference is we have to do a dual antiplatelet. So we add the clopidogrel. Instead of just giving the aspirin, we give the aspirin plus clopidogrel. Okay, so dual antiplatelet. So that is the one important thing you have to notice here. Now we this is the first mainstay of the therapy for the NSTEMI. Now we classify the patient if the patient is high risk patient. So now the patient is kind of stable now. Now we have to make sure that patient is not going to have the recurrence, or recurrence of heart attack or anything in the future. So now we have to do more treatment on patient. So for that, we classify the patient if the patient is high risk or non-high risk. So high risk means here high risk for the recurrence and heart attack. So it's not high risk of bleeding, it's high risk for recurrence and heart attack. If the patient have a high risk for recurrence and heart attack, so how do we assess that? We have the something called STEMI, which we'll be discussing shortly. It's a score to assess the risk of recurrence and heart attack in patients with myocardial infarction. We use it like post-MI, so it's not for the diagnosis. So we call it TIMI stands for thrombolysis in myocardial infarction score. Okay, and if the TIMI score is like more than 3, and we check for the cardiac markers. If the patient have a troponin, we said recurrent ischemia. If the patient have a history of recurrent ischemia, hemodynamically unstable, so that which means the patient is hypertensive or the patient is hypoperfused. And if the patient have ventricular tachycardia and heart failure, if the patient ejection fraction is less. So those are the patients, if the patient have a history of CABG or PCI in the field, so patient have a history like open heart surgery, or if the patient had a history of percutaneous coronary intervention, those are the high risk patients. So in those patients, after the treatment with all these medications, we have to do angiography or revascularization. So if you notice here, even though it's partial block, as it is high risk, we do the invasive here. So if you notice, the CABG or open heart surgery, it's only done in NSTEMI, okay? So it's always a choice in NSTEMI, but in STEMI, we only do the PCI. So that is the difference you have to notice here. So in NSTEMI, open heart is the choice. It's always doing NSTEMI patient, unstable angina patient, not in STEMI patient. In STEMI, we usually go with the percutaneous coronary intervention, okay? So here we can do both. So we do the angiography and revascularization. Then after that, we start or we continue this aspirin with the clopidogrel, the dual antiplatelet. So we start the patient on the dual antiplatelet therapy. So we usually go with one platelet and the dual antiplatelet. So after the PCI, if the patient is undergoing the PCI, we don't need to don't have to start the heparin again. So after the PCI, so we can stop the heparin. So like we said, like we actually given the heparin for 2 to 5 days, right? So after the PCI, we only have to continue the dual antiplatelet. We don't have to continue the heparin. Okay, so are we clear? So again, we continue the oxygen, we start the nitroglycerin. If there is ongoing ischemia and recurrence, we give the long IV beta blockers, and still, despite support, it's still pain, we give the IV calcium channel blockers. Then we give the low molecular weight heparin. Unlike in STEMI, we go with the unfractionated first. Here we go with low molecular weight heparin first, and we give it for 2 to 5 days, right? And we also start the patient on dual antiplatelet. That's the difference again. Now we categorize the patient based upon high risk or low risk. High risk patients, we have certain criteria to assess if the patient is high risk or low risk. If the patient is high risk, we have to do the angiography or revascularization. So we have the CABG, we have the PCI. So if you notice, the difference is we only do the open heart in STEMI patient. We don't do it in STEMI usually. We go with PCI in STEMI. And after the revascularization or after the procedure, we start or continue the patient in dual antiplatelet. And do we have to continue the heparin? No, we don't have to, especially after the PCI. Okay. All right. What if it is non-high risk patients? So non-high risk patients, we actually treat them the same way we treat the post myocardial infarction patients. So even if it is STEMI or unSTEMI, we do a post MI management. So we'll be discussing the post MI management in next slide. So what is the goal of post-MI management? So the post-MI management, the goal is to prevent the mortality, complication, and recurrence. It's pretty simple. Like we have to decrease the mortality of the patient, like to prevent the mortality, not decrease, prevent the mortality, to prevent the complications from happening, to prevent the recurrence of MI. So what we do usually in post-MI, we give the patient dual antiplatelet, we give the patient beta blockers, ACE inhibitors, high-dose statin. So if you could notice here, it's actually the same way we did the treatment in angina. So in angina, we give the patient high-dose statin, ACE inhibitors, and antiplatelet. The only difference is here is we giving the dual antiplatelet instead of just giving the aspirin. We are giving the patient dual antiplatelet. Okay. So again, why it is really important to do this? It seems to have that statins and ACE inhibitors have a very good role in decreasing or to prevent the mortality. So that is the reason we are starting. So we know that the patient is already on beta blockers. So and dual antiplatelet, the additional is ACE inhibitors or high-dose statin. Okay. If the patient is having just think about this. If the patient already have a previous history of stable angina, now the patient is having the myocardial infarction, probably the patient is already on these medications. Here, probably the physician has to titrate the dose or check for the doses if the doses are accurate. So they will just continue the medication what the patient was on previously, and probably they will add just with the aspirin they will add clopidogrel. So the patient has to do dual antiplatelet. So if you relate and study the things, you will know the difference, and it will be easy for you. Now let's have a look of what are the dual antiplatelets usually used. So for 1 year, so what is the duration we give for 1 year at least? So it is better to consider 3 years, but at least for 1 year we have to make sure that patient is on dual antiplatelets. So what is the best choice always? For high risk of bleeding, we give the patient start the patient on aspirin and clopidogrel. So again, for high risk of bleeding. For PCI patient, we give aspirin and ticagrelor. So ticagrelor have high risk of bleeding. That is the reason we don't give that in high risk bleeding category patients, but we give it for the PCI patient. Okay. Now, for low risk, like the NSTEMI, we said the low risk patients in NSTEMI, we can just give the aspirin, or sometimes the physician choose not to add the clopidogrel or ticagrelor. So you can give aspirin alone too. Now, what if the patient is having CAPS? So we discussed that patients, what if the patient is already on taking the aspirin, and now the patient is having NSTEMI, and patient is categorized as high risk patient, and now the doctor wants to go for an open heart surgery. So in that case, we have to hold the medication 5 days before the surgery. So we discussed in antiplatelet, it's actually 5 to 7 days kind of thing, right? So minimum at least 5 days before the surgery. Now, what are the beta blockers? So we start the beta blockers within 24 hours, and we titrate every 12 hours, and we make sure the target heart rate is 50 to 60. So we titrate the dose, and we can start the IV, then we can switch to oral later. So we give the IV in NSTEMI, right? So we can give the IV first, and then we can switch to oral. We can titrate the dose. So the target heart rate has to be 50 to 60 beats per minute. And when it comes to ACE inhibitors, it is within 24 hours. If the patient is not on ACE before, we have to start within 24 hours. We titrate every 24 hours for inpatient, and if it is outpatient, we cannot do it every 24 hours. We cannot ask the patients to come every day, right? So we do it like 1 to 2 weeks for the outpatients. Now, high dose statins. So we also start the patient on statins. So coronary artery disease is one of the commonly caused for the angina and stuff. So we have to make sure we start the patient on high dose statin. So we give most commonly used is atorvastatin and rosuvastatin. So 80 milligrams of atorvastatin and 40 milligrams of rosuvastatin. So the target is to decrease the low density lipoprotein to less than 2 millimoles per liter, or we can say that 50% reduction from baseline. Okay, and if they have to give a combination, if there is no reduction, 50% reduction just with statins, if the physician have to go for a combination, the best combination and preferred combination is to combine the statins with acetrol or ezetimibe. Acetrol is a brand name, guys. Sorry. So ezetimibe. So we start the patient with statins with ezetimibe. Okay. Now, are we clear so far?
Yes, ma'am.
Okay. Now, additionally, there are a few things we have to add on to treat the complication. So, for example, if the patient is already on angina, only we have to do is like a patient is already had previous history of angina, and if the patient is already on beta blockers, like I said already, calcium channel blockers, or the patient is on ACE, antiplatelet, or statins, we only have to optimize the therapy. So I already mentioned that. And now, what if the patient have heart failure? So that means if the patient seems to have a ejection fraction of reduced ejection fraction below 40%, we have to make sure that, so the patient is already on beta blockers and ACE inhibitors, right? So I didn't put that drug. So when I discussed the heart failure, we said that beta blockers, ACE, and MRA is the triple therapy for the heart failure. So here I added the MRA. So we can, based upon if the patient have a congestion, we can give the loop diuretics. If the patient have a persistent symptoms of heart failure, regardless of MRA and loop diuretics and the beta blockers and ACE, we add hydralazine or nitrates. So we already discussed all this in heart failure. So you should know that. Now, tomorrow we'll be discussing about the cardiac arrhythmia. So, but here, for if the patient have a AFib or flutter, we give the beta blockers to control the heart rate. So, and we have to optimize the strength of the beta blocker. If the patient have AFib or flutter, which we'll be discussing tomorrow, then we also give the anticoagulants or antiarrhythmic if needed in those category. If the patient have pericarditis, what we do is we start the patient on naproxen or steroid. And here the question you should ask me, why we are giving NSAIDs. The NSAID is one of the class of medication that we should not use in patients with cardiovascular event. But so naproxen, that's the reason we choose the naproxen. So if we look into the class of medication NSAIDs, naproxen is the drug which have least effect on cardiovascular side effects. So that is the reason we choose the naproxen. If the option was ibuprofen, I would say no. So if the physician ask your suggestion which NSAID is better, especially if the patient have a underlying cardiovascular condition, we have to choose naproxen. Okay, so naproxen is the least have least side effects. So naproxen is the best choice if the patient has to take the NSAIDs. And so there is an inflammation, so we have to give the steroids for the patient if the patient have depression. So usually it's very common, depression is very common post MI. So we give the SSRIs, selective serotonin reuptake inhibitors. Okay, and patients sometimes have anxiety, so we have to treat all these things, anxiolytics. So we don't have patients to have more stress and stuff. So it's really important to make sure that patient is getting an optimized therapy and touches every things are like if the patient have depression, we have to treat the depression. If the patient anxiolytic, sometimes we can give the anxiolytic agents for the anxiety. And it is really important after the post MI to monitor for the troponin, ECG, left ventricular ejection fraction, right, and the chest pain. So that is not chest app, it's chest pain, guys. Sorry. So and heart rate. Again, we have to do a serial troponin after the post MI to make sure that patient is not having a recurrence, right? ECG is really important. And left ventricular ejection fraction. Why? Because now the patient is already having a heart attack. The chances of heart remodeling is very high, and it can lead to heart failure. So it can progress into a heart failure. So we have to always check the left ventricular ejection fraction for those patients post MI and the chest pain. Okay. Okay. Chest pain. All right. Okay. Now, so here's the that I discussed you guys with TB score, right? So TB score is nothing but thrombolysis in myocardial infarction score. Okay, so how do we know? How do we do the TB score? Take the TB score is like if the patient is above 65, they get 1 point. If the patient have more than 3 cardiac risk factors for CAD, the patient gets 1 point. So what are the cardiac risk factors? Like if the patient have hypertension, if the patient have diabetes or hyperlipidemia, if the patient have a smoking history, or if the patient family history. When I say family history, I discussed in angina that first degree relative, right, with myocardial infarction. So it is less than 55 years of old for males and less than 65 years of old for females. And if the patient have a known coronary artery disease of coronary artery stenosis, okay, so if the patient have a prior stenosis of more than 50%, then the patient gets 1 point. If the patient have a more than 1 episode of angina, the patient's again like severe angina in less than 24 hours or last 24 hours, the patient gets 1 point. If the patient troponin is elevated, so elevated cardiac markers, the patient gets 1 point. If there is a ST segment deviation of more than zero point 0.5, they say, but as if there is a ST segment deviation, the patient get 1 point. So we said high risk patient is for patients with more than or equal to or more than 3 points, right? So if the patient having more than 3 points, that we classify the patient in high risk category. Okay. All right. There is another one as per we call it GRACE. So GRACE stands for Global Registry of Acute Coronary Events. So we also use that score to assess the risk of mortality in patients with NSTEMI, but and it also offers the better prediction compared to TIMI. The thing is that it is more complicated, so that is only the drawback of GRACE. But so we usually see physicians use the TIMI score rather than GRACE in the practice setting. Okay. All right. Now, let's touch the anticoagulants a little bit. So that's all about acute coronary syndromes. Do you guys have any questions? No questions?
No, ma'am.
All right. Okay. So now let's have a look at the anticoagulants. So here we are going to discuss about warfarin. So warfarin. So we have the new oral anticoagulants. So I'm not touching that. I'm just focusing on warfarin here. So what is the mechanism of action of warfarin, guys? So warfarin actually inhibit the VCOR, right? What is VCOR? So we know that we have the prothrombin precursor. So it has to carboxylase to prothrombin and it makes the prothrombin, right? So for the carboxylase reaction, what happens? We need the VCOR. Vitamin K is responsible for the carboxylation reaction. So here the VCOR is the enzyme responsible for. So VCOR stands for vitamin K epoxide reductase. So that is the responsible for to make convert the active vitamin K to inactive vitamin, like inactive vitamin K to active vitamin K. Sorry. So basically the warfarin inhibit this VCOR enzyme. Okay. So that's how it works. And what are the factors that so what are the factors mainly we see the reduction by the action of warfarin is like factor 2, 7, 9, 10. So it's really important to know the factors. So in unfractionated heparin and in heparin we said it is 2 and 10. Here it is 2, 7, 9, 10. So usually we remember it is like 1972. So 972 and 1, like we call it, like we consider it as the 10. So we usually remember the warfarin is 1972. Okay, so that's a tip. Now, what are the indications for warfarin? So we use it for the prevention and treatment of DVT, and we also use it for the prevention of stroke in patients with AFib. So here, if you could notice, we don't use the warfarin like in all the cardiac conditions that we discussed earlier. We usually use it for exception is stroke in patients with AFib. We'll be discussing it tomorrow. Commonly it used for the prevention and treatment of warfarin, DVT. Okay, deep vein thrombosis. What are the some contraindications here? So contraindications, there is a pretty much big list of contraindications. So I try to put a little bit here. So in pregnancy with or without eclampsia, or females with preeclampsia, or and also in first trimester, we should not use warfarin. Why we should not use first trimester? So usually we all know that it can lead to bleeding. So that is one of the reason. But the main reason why we should not use in first trimester is because there is a high risk, especially between week 6 and 9. There is something called fetal warfarin syndrome. Basically, it is nothing but like what happens is it actually leads the use of warfarin leads the it leads to failure to develop the nasal septum, and it can lead to nasal hypoplasia for the fetal and also the nasal depression. So and can result in airway obstruction. So that is the reason. So again, something called fetal warfarin syndrome. If you use the warfarin in first trimester, can we use in second and third trimester? Actually, no. But if there is a compelling indication, we have to use it. Yes, but it actually has less common effect. So Actually, it can lead to low birth weight and optical nerve atrophy and hypoplasia. So it's fine. The hypoplasia of the extremity. So it leads to short finger, dystrophy and stuff. So usually it leads to developmental retardation, we can call it. So again, in pregnancy, we have to be very careful. We cannot use, especially if the patient have a preeclampsia or even if it is with or without eclampsia, warfarin is contraindicated. What about active and uncontrolled bleeding? We cannot use the warfarin. It's pretty obvious if the patient have a active or uncontrolled bleeding of cardiovascular bleeding, if it is genitourinary bleeding or GI bleeding, it doesn't matter. If it is respiratory bleeding, it doesn't matter. We cannot use warfarin. Can we use warfarin in menstruation? Yes, we can use. It's not considered as a bleeding. We can use in menstruation. Sometimes the patients feel like the females can experience menorrhagia, which we can call it as increased um, bleeding, but it's fine. So what we can do to manage that, we can give the hormonal contraceptives if the patient has to have a menorrhagia associated with taking warfarin during the menstruation time. Okay, to decrease the bleeding, we can give the hormonal contraceptive. Now, if the patient have a history of warfarin-induced skin necrosis, we have to be very careful when we use the warfarin in those category of patient. We all know, pretty much aware about the purple toe syndrome, one of the adverse reaction of the warfarin, right? We'll be discussing that later. And if the patient is unsupervised patient, why? Because in INR is one of the important thing that patient has to do to monitor the warfarin response, right? So if the patient is unsupervised, that means uh, if there is a lack of patient cooperation, if patient says that, oh, I cannot go every week or like 3 weeks to take the INR, then can we start the patient on INR? Warfarin? No, we cannot. If the patient is unsupervised, like homeless people, they cannot able to go and do the INR, right? So we cannot do the warfarin. We cannot initiate warfarin in those patients. And there are others condition contraindications as well, like surgery involving large open space, if the patient have a hemorrhagic tendency, so there are a lot other contraindications. So these, at least these are the important one we have to know. Now let's have a look at the adverse drug reaction. Okay. Serious adverse drug reactions include, so here I mentioned the serious adverse drug reactions. So serious drug adverse reactions includes bleeding. So the risk of bleeding increases if the INR is above 4 and if the age is above 65. And if the patient is having uncontrolled hypertension, like if the patient is having uncontrolled hypertension, or if the patient have a history of GI bleeding, or if the patient have a long duration of treatment, the risk of bleeding is very high in those patients. If the patient have a liver disease, or if the patient have cancer, and if we co-administer the interacting drugs, we know that there is a big drug interaction list for warfarin, right? Warfarin is one of kind of drug which interact with pretty much everything. So if we co-administer the warfarin with this interacting drugs, there is risk of bleeding. And skin necrosis, like I mentioned earlier, purple toe syndrome. So usually the skin necrosis is due to mobilization of the plaque emboli. So for example, it actually appears as a purple toe syndrome. It actually is reversible, usually it appears in 3 to 10 weeks after initiating the treatment. And sometimes it can progress to gangrene, which is really not a good condition, and it actually end up in amputation, but most of the time it is reversible, so it's fine as long as we maintain the warfarin dosing regimen. We adjust the warfarin dose based on the INR, everything is fine. If we don't, it actually can lead to purple toe, it can lead to gangrene, and it requires the amputation and end up in amputation. Now we have other non-specific adverse drug reaction as well, like vomiting, diarrhea, um, abdominal cramps, and so, which at least you have to remember this serious adverse drug reactions. Okay. Now I haven't mentioned the drug interaction that you can go home and like you can check for the interaction list of warfarin. There is pretty much a very big list of drug interactions. So I didn't touch that part. Now let's have a look at the monitoring protocol for the patient. So as we all know, INR should be monitored in after initiating the warfarin therapy, or if we change the warfarin dose, or if we are starting or discontinuing an interacting drug. So these are the three situations we have to monitor the INR. So again, what are the situations? If for new patients, when we initiate the warfarin therapy, we have to monitor the INR. Now, if we are changing the warfarin dose, if the physician is changing the warfarin dose, the patient has to do the INR. If the physician is starting or discontinuing a new interacting drug, then again the patient has to monitor the INR. So pretty much in every situation, the patient has to monitor the INR related to warfarin. Okay. Now let's see how do we do the monitoring. So in new patients, when we initiate the warfarin, in the first week, day 3 and 5, we do the monitoring. Again, in first week, we do the day 3 and day 5. So before speaking about the monitoring, what is the actually duration of action of warfarin, guys? Anybody know what is the duration of action? So duration of a single dose is like 2 to 5 days. Okay. So whenever you see this, you have to remember this date again. The duration of a single dose. So once the patient take the warfarin today, its effect can last for 5 days. Okay. Why it is important to know? Because you have to know this number in order to adjust the dose, especially if the patient is undergoing an elective surgery or emergency surgery, or especially when it comes to monitoring, we have to know this day. Again, the one single dose duration is 2 to 5 days. Okay. Now let's come back to the monitoring. So week 1, we do the day 3 and day 5. In week 2, we check the INR twice a week. So we do it like in week 2, we do 2 times. So we don't want to do like on a consecutive days. We have to do like in the first day or like in the third day, So just 2 days. It doesn't have to be day 3 and day 5. It has to twice, but make sure that it's not doing like in a consecutive day. Now in week 3, what we do is like once the patient reach on week 3, we take the INR weekly till the INR reaches within range, and we do that for 2 weeks. Okay. So again, the patient is on week 3. Now we do it for weekly until the INR reaches within the range. So what is the range? 2 to 3. So 2 to 3 is the range for most of the patient. So again, I mentioned the target INR and below. 2 to 3 for most patient. If the patient having mechanical valve, then it is 2.5 to 3.5. Okay. So again, in week 3, we do it weekly till the INR reaches within the range. We do it that for 2 weeks. So now the INR reaches the range. Okay. For 2 weeks, we did weekly. Now what we do? Then now we go every 2 weeks. Every 2 weeks till within the range. So we have to make sure that it's again within the range, and we do that for 1 month. If the range, if still the patient until the first month, like the patient is like for 1 month, patient is in the range. Now we go for monthly. So again, the patient is within the range. So if it is monthly for 3 months, then if the patient is still on the range for 3 months, then we do it every 3 months. So don't confuse. First week we do for day 3 and day 5. Week 2 we do it like twice in that week. In week 3, first we do weekly for 2 weeks. Okay, take out the part within range. It has to be within range in all situations. So weekly for 2 weeks, then every 2 weeks for 1 month, then monthly for 3 months, then every 3 months. But one thing I have to mention, you never ever see a patient who does the INR every 3 months. Why? Because it's really important to keep the INR in range. So mostly the patient can reach, maybe you will see patients taking it every month, maybe or every 2 weeks. You never see a patient who does the INR every 3 months, unless the patient don't want to do an INR and like save money. You will see. But if the patient is regularly monitoring the INR following the protocol, it's hardly you will see patients who reaches in a stable level where they have to do every 3 months. So it's really hard to maintain the INR for the warfarin. When it comes to warfarin, it's really hard to maintain the INR. So what if changing the warfarin dose? So if we change the warfarin dose, we do it weekly till patient is already initiated, right? Now there is a change in the warfarin dose. The doctor has decided to increase the warfarin dose. Okay, so we after changing the warfarin dose, we monitor the INR for weekly until it stables. Then we go back to the week 3 procedure. So we go back to the week 3 where we do. So we do the weekly for 2 weeks, then every 2 weeks for 1 month, then monthly for 3 months. So we continue that. If the patient is if the physician is starting a new interacting drugs, for example, levothyroxine or something, um, we take the INR in 3 to 5 days. Okay, then why 3 to 5 days? Again, that's the days you will see if there is change or if there is once we initiate the therapy, like I said. So INR in 3 to 5 days, then weekly as above. We'll go back to the same weekly as above. So weekly for 2 weeks, then every 2 weeks, then monthly, then every 3 months. Okay. So again, what is the target INR? 2 to 3 in most patients and 2.5 to 3.5 mechanical valve. Now, let me ask you guys a question. What is the likely effect of starting levothyroxine on warfarin dose? So if the patient diagnosed as hypothyroid and the patient is on warfarin, now the physician wants to start the levothyroxine. What is the likely effect of starting levothyroxine and warfarin? Anybody? So starting the levothyroxine will not change the warfarin dose upfront. So that is the one thing you have to know. So we know that warfarin, what happens? Warfarin actually increases the effect of warfarin, right? Sorry, levothyroxine increases the effect of warfarin. But starting the levothyroxine, it will not change the warfarin dose upfront. But there are few cases we do the adjustment. So once we start the levothyroxine on the patient, do we need to change the dose upfront? Actually, no, because levothyroxine will not change the warfarin dose upfront. But again, there are few cases we do adjustment upfront. For example, if we is starting the patient on amiodarone, see, antiarrhythmic, it can reduce the warfarin dose upfront. So in that case, we have to adjust the dose upfront. But in levothyroxine, it will not change the warfarin dose upfront. So we don't need to do the adjustment upfront. So what happens again? Levothyroxine increases the effect of warfarin dose. So what we have to do in this situation, we have to, usually we don't have to change the warfarin dose, but at some point we have to adjust the dose. So levothyroxine increases the effect of warfarin. So we have to reduce the warfarin. Now the thing is, do we have to do a long-term reduction or short-term reduction? We have to do a long-term dose reduction on warfarin. Why? Because levothyroxine is one medication that patients has to take for long-term, right? It's not just for 3 days or 5 days. Okay, let's see another example. What if it is rifampin? So what is the likely effect of starting rifampin on warfarin dose? We know that rifampin is an enzyme inducer, right? So what we have to do? It's an enzyme inducer. So that means rifampin can decrease the effect of warfarin. So do we have to do a long-term dose reduction or short-term dose increase or short-term dose reduction? What is the answer? So,
Dose increase.
dose increase, is it short-term or long-term? Short-term dose increase, right? Now, another example. What is the likely effect of starting ciprofloxacin? Ciprofloxacin with warfarin. What is the likely effect? Do we have to decrease the dose or increase the dose? So ciprofloxacin increases the effect of warfarin. So what we do? Decrease the dose. Yes. Do we have to do it long term? Why long term? It's not long term. Why do we give ciprofloxacin for a long term therapy? It's an antibiotic, so it's always short term, right? So it's short term dose decrease of warfarin. Okay. What if it is phenytoin, guys? Phenytoin is an enzyme inducer. Okay. What if it is phenytoin? In that case, we have to do a long term. Why? Because phenytoin is used in seizures, and seizure patient has to take the medication for a long time. So we have to do a long term dose increase of warfarin. Okay, perfect. So that's how you guys relate the interactions and study. We have to make sure if we have to do a long term dose adjustment or short term dose adjustment. Do we have to reduce the dose or increase the dose? Okay, so those are the two factors. All right, now we discussed the monitoring protocol, right? Now, what is the duration of treatment for warfarin? So duration varies according to the indication, right? So, for example, if the patient is on mechanical heart valve, we give it for long term, and also in patients with AFib, we have to give it for long term, and also in DVT, recurrent DVT, we give it long term therapy, warfarin. Okay. So those are the three conditions we give the long-term warfarin. Again, mechanical valve replacement, atrial fibrillation, and recurrent DVT. And if it is like if there is a undergoing cardioversion in AFib patients, we just give it 3 to 4 weeks prior to the cardioversion. So again, the warfarin 3 to 4 weeks prior to cardioversion. If the patient has a bioprosthetic valve, so we discussed about the mechanical valve, but if the patient having a bioprosthetic valve, we gave it for 3 months. The duration of treatment is 3 months. Bioprosthetic valve, you should know it's something made from the animal tissue, and it's not going to last. Why it's just for 3 months? Because there is a high chance the patient has to replace the valve at some time. Mechanical valve, they can use it like once it replaced, that's it. Patients can live with that forever. But bioprosthetic valve, it has to be replaced. I don't know how long, but it has to be replaced at some point of time. Okay. Now, what are the factors affecting INR? Let's discuss some factors about affecting the INR. So we can see the genetics. So if the patient, some patients will have the changes in VCOR and VCOR, right? So we discussed what is VCOR. So VCOR, sometimes patients have more VCOR, maybe some patients have less VCOR. So, right? So those can affect the INR. Lifestyle, diets, right? Many drugs, there are a lot of interactions. So everything, pretty much most of the drugs that interact, and everything interacts with the INR too. We know the diet, green leafy vegetables, right? So there are a lot of things. So blood thinners can increase the warfarin effect, right? Like acetyl salicylic acid and stuff. And if the one thing I have to notice here is the alcohol intake. So if the patient doing binge alcohol, it increases the INR. Okay. But if the patient is long-term heavy drinking, it decreases the warfarin. So alcohol actually can increase and decrease based upon how patient use the alcohol. So if the patient is a binge alcohol drinker, then it increases the INR. If the patient is a long-term heavy drinker, then it decreases the warfarin. Okay, so that you have to remember. Now, what are the few counseling points we can tell patients when we initiate the patient on warfarin? We have to tell that if the patient is, we have to make sure that patient is not taking any other medication that can interact or inhibit or increase the bleeding, right? Okay, we did that. We have to tell the patient to screen the INR. Okay, that are the two things. What is the important thing that we have to educate the patient while the patient is on warfarin? Anybody? We have to educate the patient to monitor if there is an increased bleeding. How the patient can monitor the bleeding? Yes, bleeding, right? How do we educate the patient? So we have to tell the patient to look out for any unexplained bruising. So if the patient hit and got a bruise, Can we consider it as the side effect of warfarin? No. If there is unexplained bruising or unexplained nosebleed or unexplained gum bleed or unexplained blood in urine or in stool or unexplained vomit of blood, so those are the things that we have to tell the patient to look out for when the patient is on warfarin. What if the patient missed a dose? So if the patient missed a dose, we tell the patient to take it as soon as the patient remember it on the same day of the dose. If the patient does not or cannot take it at the same day, then the dose has to be skipped. We don't want the patients to take double the dose the next day. Okay. So again, if the patient missed the dose and if the patient remembers it on the same day, then we can ask the patient to take the day on the same day. Dose on the same day. If the patient does not or cannot take it, then the dose has to be skipped, and make sure the patient is not doubling the dose. Okay. And it is really important to tell the patient once you miss the dose, you have to monitor the INR the next day. Okay. So the patient has to monitor the INR after missing the dose. All right. Okay. Now, what are the antidotes we use in warfarin overdose? It's pretty much easy. Vitamin K, right? Okay. So we use the vitamin K. So we usually assess the bleeding, right? And in the absence of bleeding, we can actually omit the dose or one or more doses, or we can decrease the dose and we can monitor carefully. Okay. In the absence of bleeding. So that means that the patient, instead of taking 2 milligrams, and the patient ended up taking 4 milligrams, and the patient have no bleeding. That means it's okay. We just have to. Do we have to give vitamin K? We don't have to. We just have to omit the dose. Maybe we have to omit one or more doses. Then we have to decrease the dose and monitor carefully. If the patient have INR above 9 and there is no bleeding, okay, again INR is above 9 and no bleeding, then we have to add vitamin K orally. So we give the vitamin K orally. So again, if the INR is above 9 and no bleeding, we give oral vitamin K. If the patient having bleeding, in that case, we have to give the intravenous vitamin K. Okay. All right. Now let's have a look at how we do the adjustment of warfarin dosing based upon the INR on non-bleeding patient. Okay. Again, we are discussing about non-bleeding patient. If the patient is bleeding, we have to excessive bleeding and stuff. We have to make sure we give the vitamin K intravenously. Okay. So here we are discussing adjusting the warfarin dose in non-bleeding patient. So again, it's really easy to understand. It's not very complicated. So there are, having said that, there are other antidotes too, guys. So vitamin K, sometimes in we see physician use factor 4A prothrombin complex, or they use the fresh frozen plasma. So vitamin K is the first mainstay antidote, but still they can use all this, the recombinant factor 7A and fresh frozen plasma. Okay. Now let's see how to adjust the warfarin dose here. Non-bleeding patient. So here the target is 2 to 3, because when the patient is on warfarin, the target is 2 to 3. We know that. So first, just focus on 2 to 3. So in 2 to 3 2 to 3, we don't need any adjustment, right? So no adjustment is required. And the next INR is when due. So we discussed the monitoring protocol. So based upon that, we just continue. There is no difference. Now, let's see, what if it's below 2? So that is the one thing. So there is only one step below that. So if it is below 2, what we have to do, obviously, if it is below 2, that means the blood, we have to increase the dose. So how do we increase the dose here? We always do the dose increase. So the second thing you have to remember here, so first thing, the target INR 2 to 3, no adjustment required. Second thing, we always increase the weekly dose. Okay, we don't increase day by day, every day. We increase or decrease the dose. Wherever you see, there will be an increase or decrease dose in weekly doses. Okay, so bi-weekly. So not bi-weekly, we increase the dose weekly. Okay. don't use the term bi-weekly. So I was using like not bi-weekly. Okay, so we increase or decrease the dose weekly. So how, like, so if you see, so at least you have to remember if you're increasing the dose or decreasing the dose. Even if you don't remember, again, like I said, like when I discussed the adjustment in heparin, in antiplatelets, we discussed that even if you don't remember the percentage, at least you have to remember how are you decreasing the dose or increasing the dose? Are you holding or you're stopping the infusion? In heparin, we said stop, right? So are you stopping it, or do we have to stop the infusion, or do we have to hold the dose, right? So here we have to increase weekly. Okay, so the percentage is 10 to 15. So it's actually like 10 to 15, 5 to 10, 10 to 20. So it's actually within range of 5 to 20. So it's not too much. It's not 50% dose reduction, or it's not 60%. So the range is within 5 to 20. So that is the another tip. So again, you have to know the target. You have to know if you're decreasing. So the second tip is we decrease weekly dose. Okay. So again, not daily. We decrease the weekly, and percentage is between the range of 5 to 20. Now, if it is below 2, we increase the weekly dose by 10 to 15, and the next INR due or 5 to 7 days. Why? Because the duration of action of Warfarin is 2 to 5 days. So wait for 5 days, and so we are changing the drug. So we take the next INR in 5 to 7 days. So you should also know the onset of action, guys. The onset of action of warfarin is so the anticoagulation effect peaks at 3 to 4 days. So that is the another reason we check the INR in 5 to 7 days. So when we change a dose today, we cannot check the INR the next day. So it's going to give a time like 3 to 4 days. Okay, it's not just the duration of action. 3 to 4 days is the anticoagulation. So it reaches the peak of anticoagulation at like 3 to 4 days. Now let's see if it is between 3.1, between 3.1 and 3.5. So remember that. So 2 to 3, now less than 2 we discussed. Now 3.1 to 3.5. Okay. And here we have to decrease the weekly dose. So again, the only condition we have to decrease or increase, if we have to increase, if it is less than 2, we have to decrease if it is 3.1 to 3.5. Okay, so how much reduction? 5 to 10% weekly dose. Okay, now let's check here. Above 9. So we checked less than 2. We know that if it is 3.1 and 3.5, we have to decrease the weekly dose. Now, if it is more than 9, so I'm just skipping the rest two of the between numbers. So let's jump right into more than 9. Okay, so more than 9, what we do more than 9? So we discussed if it is more than 9, the only thing here difference is that we have to add vitamin K. So between 3.1 and 3.5, the rest of all situation, we have to hold the dose and also decrease the dose, weekly dose. So if you notice, in most of the situation, if it above 3.5, so we can say if it is above 3.5 and the physician asks you, the suggestion recommends, like, what should I do in this situation? You have to say, hold the dose and decrease the weekly dose. Again, hold the dose, decrease the weekly dose. And in only case we add the vitamin K is if it is INR is above 9. Okay. So once we add the vitamin K, make sure we check the INR next day. Why? Because vitamin K is an antidote. Here we cannot go with the onset of action or duration of action. So we have to do the INR in the next day. The next INR is next day. Okay. So again, if it is below 2, decrease the weekly dose. If it is above 3 to 3.5, increase below 2, increase the weekly dose. If it is above 3 and between 3.1 and 3.5, we have to decrease the weekly dose. In rest all other situation, if the INR is above 3.5, we have to hold the dose and decrease the weekly dose. And only situation we add the vitamin K is if the INR is above 9, and in that case, we have to check the next INR in next day. Okay, be clear. Now we focus on the two categories that we missed here. So if it is 3.64, so we take 4. So 4 has the dividing number. So 3.64. In that case, we have to hold only one dose. Okay, we hold only one dose and we decrease the weekly dose by 10 to 20%. And the reduction percentage is same in both situations. The only difference is the number of dose we hold. So we hold one dose in 3.64, but in 4.1 to 8.9, we hold 2 doses. So it's pretty much easy. And the another difference is when the next INR is due. So in the first situation, it's 5 to 7 days. It's fine if we are holding one dose. But if we are holding 2 doses, just remember, we're holding 2 doses. We have to do it in 2 days, the next INR. Okay? Now, we cannot hold more than 2 doses actually. So that is the reason we increases the, when it comes to more than 9, we decreases the weekly dose by 15 to 20%. Rather than like 10 to 20, we decrease the weekly dose by 15 to 20%. So we hold the dose, we actually decrease the weekly dose by 15 to 20%. If you see in previously, it's just 10 to 20%. So there is a range, guys, here. So there is a range. So if the physician asks and you say that it's 15% reduction, there is no wrong because it's 10 to 20, between 10 to 20, right? So there is no big difference. Only we have to remember how many doses we have to hold and when we have to add the vitamin K. The percentage doesn't really matter. So again, how many doses we have to hold, how many do we have to decrease or increase the weekly dose, and when we have to add the vitamin K. Okay, so it's really easy. So this is all about adjusting the warfarin dose in non-bleeding patient with target of 2 to 3. Okay, now how do we manage warfarin perioperative? If the patient have a elective surgery, how do we manage the warfarin? So here actually the management table was a very complicated one. So here I tried to reduce it really well. So how do we assess, do the management is by assessing if the patient is undergoing a high risk of bleeding surgery, or if the patient have a high risk of thrombosis, and what to do in that situation. Okay, so again, if the patient is going on high risk of bleeding surgery, having high risk of bleeding, so what are the surgeries with high risk of bleeding? Give me a few examples, guys. So like neurosurgery, certain cardiac procedure like open heart surgery have high risk of bleeding, right? So vascular surgeries like total hip replacement surgeries, pretty much all the general surgeries is high risk of bleeding. So you should know all the you don't have to know all the high risk bleeding. What I would say, so we can actually categorize the surgeries into high risk of bleeding, moderate risk of bleeding, and low risk of bleeding. So if we know the low risk of bleeding, whatever the low risk of bleeding and very low risk of bleeding. So if we know the low risk of bleeding surgeries, whatever the surgery is not included in low risk, it's high risk. And for high risk and moderate risk of bleeding, we do the same kind of bridging. So if you notice here, if the patient have high risk of thrombosis, it doesn't matter if the patient undergoing a high risk of bleeding surgery or moderate risk of bleeding surgery, we do the bridging. So we don't have to categorize if the patient is going on high risk of bleeding surgery or moderate. Only you have to know is what are the low risk of bleeding surgeries. So let's see what are the low risk bleeding surgeries. So for example, if the patient is doing a dental extraction, dental procedure, or any kind of dermal procedure, if the patient is doing percutaneous intervention, doesn't require the open heart surgery, right? So PCI is the low risk bleeding. If the patient is doing angiograph, pacemaker insertion, or bone marrow transplantation, is a low risk bleeding surgery. or if the patient is tapping the body for any, if there is a like paracentesis, like to tapping means what? So to take the fluid out of the body, right? So if the patient is undergoing any tapping procedure, it's low risk bleeding. And skin biopsy, skin biopsy, insertion of IV needles, aspiration of soft tissue, so abscess drainage. So these are the low risk bleeding surgeries. So if you know that, rest of the surgeries which it doesn't matter if it is invasive procedure like CAP, abdominal surgery, appendectomy, liver, kidney, any kind of surgery, everything is high risk. Okay, so we can disregard the low risk, because in low risk we don't need to do anything. We don't have to discontinue the warfarin. Okay, so nothing has to be doing low risk bleeding. So we are not discussing about the low risk bleeding. We only focusing on high risk and moderate risk of bleeding. Now we should also know if the patient is high risk of thrombosis. So how do we know that? We do the TIMI score, right? So we have the TIMI score. We check if the patient had a previous history of stroke or TIA in last 3 months. If it is less than 3 months, that means the patient is high risk of thrombosis. If it is, if the patient had the TIA in last 3 to 12 months, then it is moderate risk of thrombosis. And if the patient having no history of stroke or TIA, but the patient have mechanical heart valve, that is low risk of thrombosis. Okay, so now let's classify. So the patient is undergoing a high risk of bleeding surgery, and the patient have high risk of thrombosis. Do we have to do the bridging? Yes, we do the bridging. Now the patient is undergoing a high risk, moderate risk of bleeding, but the patient have high risk of thrombosis. Do we have to do the bridging? Yes, we have to do the bridging. Okay, so regardless of it is high risk of bleeding or moderate risk of bleeding surgery, if the patient have a high risk of thrombosis, we have to do bridging. If the same situation, regardless of high or moderate risk of bleeding, if the patient risk of thrombosis is moderate, then the bridging is optional. Either the physician can choose to bridge or not to bridge. So it's optional. If the patient, regardless of high or moderate risk of bleeding, undergoing high or moderate risk of bleeding surgery, if the patient risk of thrombosis is very low or low, no bridging is required. Okay, are we good? We good. Now, let's see how the bridging is done. It's really important to know this. So here, just day -6. So day -6 of surgery, from the day we do the surgery. So we fix the surgery on 6th, then March 1st, we can say if the surgery is on 6th, then March 1st. So day -6 from the day of surgery. Okay, it's not day 6. Don't confuse. It's day -6 from the day of surgery. So that is day 6 is the last warfarin dose. So we give the last warfarin dose on day -6. In day -5, we discontinue the warfarin. Okay, so we discontinue the warfarin. Now day -3, why there is we left a gap here, because warfarin duration of action, we all know that it's 2 to 5 days. So at least we have to give a day holiday. So here day 3, so not day 3, day -3, we start the patient on unfractionated heparin IV or low molecular weight heparin subQ. Okay, so that is what we call bridging. So again, day -6, we give the last warfarin dose. Day -5, we discontinue the warfarin. Day -3, we start the patient on unfractionated heparin or low molecular weight heparin. Day -1, that is just a day before the surgery, right? So we check the INR. Okay, give 2 milligrams per oral. Okay, what we give 2 milligrams per oral, not warfarin, vitamin K, if the INR is above 1.5. Okay, If the vitamin K, we give vitamin K 2 milligrams per oral if the INR is 1.5, and at the same time we have to decrease the low molecular weight heparin dose. Okay, so if the patient is on low molecular weight heparin once daily, we decrease the dose by 50%. Okay, if the patient is on BID, what we do is like we actually skip the evening dose. That's how we reduce the low molecular weight heparin dose on day -1. So we skip the evening dose and we decrease the dose. Okay, now the day 0, that is the surgery day. Okay, so surgery day, if the patient is on unfractionated heparin, so the patient was on unfractionated heparin, we have to stop the unfractionated heparin on the day of surgery. So when we have to do is like at least 4 hours before the surgery, we have to stop the unfractionated heparin. And surgery is done. And if there is no bleeding, we resume the last low molecular weight heparin doses will be day -1 in the evening will be the last dose for low molecular weight heparin. If the patient was on unfractionated heparin, we just discontinue it 4 hours before the surgery. And surgery is finished, and if there is no bleeding, we resume the warfarin in the evening if the patient can bring fluid. Okay, so if surgery was done in the morning, we resume it in the evening. If and day +1 to day +3, if no bleeding, we resume the unfractionated heparin and low molecular weight heparin. One thing you have to notice here, we cannot discontinue unfractionated and low molecular weight heparin just like that. So we start, that's the importance of bridging. So if you're resuming the patient on warfarin, okay, because we literally hold the INR into very, so see, the INR, we literally brought down the INR into very significantly low. So the risk of thrombosis can be high if we just resume the warfarin. So we always have to give the warfarin with the unfractionated and low molecular. So if there is no bleeding, day +1, we have to resume the unfractionated and low molecular weight heparin, and we have to monitor. Then when we have to discontinue the unfractionated or low molecular weight heparin, when the INR reaches within the range, then we discontinue and we just continue the warfarin like the patient, like the warfarin dose, the previous warfarin dose. So we just continue the warfarin. One thing here you have to remember, what if we are starting, instead of warfarin, what if we are starting the patient on dapivirine, like the new oral anticoagulants? So if we are starting the patient after the surgery, instead of warfarin, the physician decides to give the patient a new anticoagulant, especially the new oral anticoagulant, that is the dapivirine. So in that case, we don't have to do the unfractionated or low molecular weight heparin. We don't have to resume the unfractionated or low molecular weight heparin. Again, remember this, if the physician decides to resume with the new oral anticoagulant after the surgery, we don't have to resume the unfractionated heparin or low molecular weight heparin. Only after surgery, the unfractionated heparin or low molecular weight heparin is given with only with warfarin, not with new oral anticoagulants. Okay, are we clear? So this is the bridging. Now, what if the patient doesn't require bridging? So in that case, it's pretty easy. We don't do the bridging, so we don't worry about the unfractionated heparin or low molecular weight heparin here. So here, day -1 before day -6 before day -6 from the surgery, we give the last warfarin dose, the same as the bridging. Day -5, we discontinue the warfarin, same as bridging. Now, day -1, we check the INR and we give 2 milligrams per oral vitamin K if it is above 1.5, same as bridging. The only difference is that we are not starting anything in day -3. We are not starting the unfractionated heparin, or we are not reducing the low molecular weight heparin dose, anything. So days -6, we'll give the last warfarin dose. Why day -6? Because 2 to 5 days is the duration of action of warfarin, right? That's the reason we have to give the last warfarin dose day -6. So it needs the time to completely eliminate from the body. So by reaches the surgery day, it has to be completely eliminated from the body. So day -6, day -5, day -1, we check the INR. If the INR is 1 point above 1.5, we give the vitamin K 2 milligrams per oral. And on surgery day, we do the surgery. Then after the surgery, we resume the warfarin in the evening if the patient can drink fluid. If the patient cannot drink fluid, or if patient cannot take the warfarin that day, then we just wait for 24 hours after the surgery to start the patient on warfarin. Okay. So whenever the like day 1 or day +1 or +3, please resume the warfarin. So in this case also, we can physician can choose to initiate a new oral anticoagulant instead of warfarin. So here we don't have to worry about unfractionated or low molecular weight heparin. So even if the patient decide, even if the physician decide to start a new oral anticoagulant, that is totally okay. Okay, but only thing you have to remember in bridging, if the physician decides to start a new oral anticoagulant after the surgery, then they don't have to give the unfractionated. They don't have to resume the unfractionated heparin or low molecular weight heparin. They can just give the new oral anticoagulants. Okay, only in case if the patient if the physician resume the warfarin, they have to give the unfractionated heparin and low molecular weight heparin. All right, so that's all about bridging. I guess it was easy. It's not that much complicated. Okay, again, we have to make sure if the patient is going on. So the patients have an elective surgery, and physician is asking suggestion or recommendation from a pharmacist, and asking how to do the bridging. Now, as a pharmacist, we have to categorize. We have to know that if the patient is undergoing a high risk surgery or a low risk surgery or moderate bleeding risk surgery. Okay, don't take high risk surgery. It's high risk bleeding. Okay, so high risk bleeding, moderate risk bleeding, or low bleeding risk. And now we categorize it. Now we came to know that it's something high risk bleeding or moderate risk bleeding. Now the second thing we have to see is if the patient have a high risk of thrombosis, moderate risk of thrombosis, or low risk of thrombosis, because the bridging is based upon that. So regardless of high risk of bleeding or moderate risk of bleeding, if the patient is having high risk of thrombosis, we have to do the bridging. We have to do the bridging. How do we do the bridging? We already discussed. We started from day -6. The bridging always starts from day -6. Even if there is no bridging, we have to discontinue the warfarin dose starting day -6. So high risk thrombosis, we do the bridging. If the patient have moderate risk of thrombosis, optional bridging. Okay, no, it's not no bridging, it's optional bridging. So physician either can choose to do the bridging and no bridging. So we can suggest the physician it's an optional bridging, and it's up to him, right? And low risk of thrombosis, we don't have to do bridging, so there is no bridging. Okay, so are we clear now? Now, what if the surgery is not planned? For example, emergency surgery. So in that case, if the surgery is like going to happen less than 24 hours, we discontinue the warfarin right away, and we give 2.5 to 5 milligrams IV vitamin K with prothrombin concentrate. So one thing here, with prothrombin concentrate. If the emergency surgery is going to happen more than if it is going to happen like more than 24 hours, then we have to discontinue the warfarin. We give the same dose of vitamin K intravenously, but it's with or without prothrombin concentrate. Okay, so that is about the emergency surgery. So that's all, guys. So that's all about the warfarin and the acute coronary syndromes. As you could see, I didn't discuss about the new oral anticoagulants here. I will touch the new oral anticoagulants when I take the deep vein thrombosis, because the anticoagulants is commonly used in DVT, and so I just left that little portion for DVT. So don't worry about it. So okay, so this is enough for today. Actually, there is a lot to study in this section itself. So that's all for today. So actually, I put an activity, but we already discussed this during the section. So I don't think you have to, but you can go with other. So we discussed the absolute contraindications, but check for the relative contraindications with and the other contraindications to the thrombolytic agents, and we'll discuss it tomorrow. Okay. All right. Do you guys have any questions? Anybody have any questions from the section? No questions? Okay. So in that case, we will wind up the section and enjoy the rest of the day, guys. And I will see you tomorrow with cardiac arrhythmia. So prepare for cardiac arrhythmia tomorrow. It's going to be an interesting section, and I'll see you guys tomorrow. Okay. Thank you so much, guys.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, guys. Thank you.